Hello, good evening, friends. So, um, we are live today to discuss the questions, the endodontics, conservative dentistry, and the dental materials questions that came yesterday in your INI May 2023 examination. Friends, um, you know, uh, the exams that we are aiming to target, right? Aiming to conquer and get a good seat. They're very different from the examinations that we used to give in our school or in our college, in our professional examinations, primarily because of the fact that, you know, these examinations have got a lot of repeat recall value. You understand? The questions that come in this, that came yesterday, will be very important for you for the upcoming next INI examination also and next year's NEET examination also. These questions will stay relevant for at least 3 years and up to 6 to 7 years, right? So it's not like, the examination is done and let us just forget about it. If we get selected, great. Not, let us just forget about it and just go ahead with our preparation. This, the conquering these questions, getting their right answers, understanding the concept, basically tells us the mentality or the mental state and the trend that the examiners are going to follow in the upcoming examinations. So these questions are extremely important, friends. And as always, if you combine cons, endo, and DM, very important. Relatively, if you see the proportion, endo and cons was more, and DM, which is again a very, very important subject, slightly less, we can say. But then that, you cannot rely on these trends because they're very interlinked subjects, right? So, I mean, you can have more DM in the coming upcoming examinations. Anyways, let us just directly go to the important points. The first question that we're taking up is caries vaccine is based on which immunoglobulin? See, friends, I cannot help you out much with, there is no concept here. This is simply a ratification, simply a memory based question in which the caries vaccine is based on immunoglobulin A. Having said that, we still do not have a successful caries vaccine in the market, but yes, experimentally, research wise, whatever prototypes we've developed, they're based on generating immunoglobulin A as an immune response, right? That's number one. Number two, again, a completely memory based, ratification based question. All right. If we are to see cry paste, what is the composition of the cry paste, friends? Then the composition of the cry paste is, it consists of roughly about iodoform in about 80%, right? Then we have camphor. I'm talking about rough figures, 5%. To be very specific, it's about 4.8 or something like that, right? Then we have parachlorophenol, which is roughly about 2%. And we have menthol, which is about 1.2%, friends. So obviously, we have to match whatever knowledge that we have. We write this down somewhere, right, in our rough paper, isn't it? And we match it with the options. Never see the options first, friends. In such a question, because the examiner is there to confuse you. So you first figure out the answer yourself and then try to match it with the options given and reach for sure the correct answer. This would ensure that you have 100% accuracy and zero negative marking, right? So the answer is iodoform, camphor, menthol, PCP. Iodoform, camphor, menthol, PCP. Right? Simple enough, completely memory based. Unfortunately, these questions, you can see these questions are still coming, friends. I mean, you see your old question banks and you realize, oh, in some state PGs, these questions used to come about 15 years back. You can just see the recall, the repeat value of such hardcore memory based questions. No logic whatsoever. I mean, if you've memorized it, well and good. If not, well, God save you. Okay, Next important, a 10-year-old child is brought to you 45 minutes after avulsion, that is X articulation, complete removal of the tooth from the socket. What is the next step? Now, there are three important hints, three pillars on which this answer is going to rest. Three important points here. All right. Three important points, friends. Number one, it's a 10-year-old child. So we are dealing with more or less, when they say classically 9 or 10-year-old child, we are dealing with a permanent tooth, which is why permanent? Normally, usually, I mean, obviously, it can be a deciduous tooth also, because 6 to 12 years is the mixed dentition state. But if you see the tooth, this is obviously based on recall value, but most likely it was an upper anterior, most likely a central incisor, something like that, right? Now, this slightly seems to be like a canine, but don't go by that. It was, as we've recalled the questions, it was mostly a, central or a lateral. So your 10-year-old permanent, so it would obviously be a permanent tooth, isn't it? Can't be a deciduous incisor because they erupt at about 6, 7, 8 years age, right? Then the second thing is that in all likelihood, when the examiner is telling you this kind of age, 9, 10 years of age, then we are dealing with a permanent immature apex tooth. That is an open apex tooth, right? The second important thing is it brought to you 45 minutes. That is less than 60 minutes. Now that's the critical value. If the extraoral dry time is less than 60 minutes, then the ability of a permanent immature apex tooth, if managed correctly, it can revascularize. Right? Now, what is that? Important condition if managed correctly? You have to either dip it in, dip it in doxycycline solution, or coat the surface of the root with minocycline powder. Right, friends? Now, if 10-year-old was given in the option, then minocycline becomes the correct answer. Right? If specifically, this question can come in another form. If in specifically the question is that it was a mature apex tooth, it was like a grown up 15-year-old, 16-year-old, or 17-year-old, I was clearly mentioned closed apex or a mature apex permanent tooth, then there is no point in even trying for revascularization. It will undergo necrosis and it will stay necrosed. So your primary aim in the first appointment would be, again, depending on whether the tooth was out of the oral cavity in the dry condition for less than 1 hour or more than 1 hour. If it was less than 1 hour, then you can achieve some sort of PDL, regeneration, normal healing of the root, and avoid replacement resorption, right? If the extraoral dry time is more than 1 hour, then there is no point in trying to save the remaining PDL, because most of the PDL is gone, it's necrosed, and the remaining PDL cells will only act to accelerate the inflammation. They would only act to call upon more osteoclasts and resorb the root. So you need to scrape off that PDL. So the management completely changes based on what the examiner is using in his question language, right? So if it's a mature apex tooth, if it comes to you before less than 60 minutes, then you simply have to reimplant it as soon as possible by simply just basic cleaning without scraping the PDL, just by cleaning it in, under normal saline, right? Or simply under tap water, even if you don't have normal saline, just splint it back, right? Don't be in a hurry to do root canal, right? Because you have to minimize the extraoral time it stays. Otherwise, the PDL cells will dry out, they will undergo necrosis. However, if the extraoral dry time is greater than 60 minutes, then you have to take that extra effort to dip it in, solution, hypochlorite solution, to completely scrape off the PDL, then dip it in APF gel or a fluoride solution like a stannous fluoride, and ensure that your root becomes more resistant to replacement resorption. That will definitely take place, but you just want to retain the tooth for as long as possible. Then the other important variation in this question is that the examiner is going to really trick you, right? He would say that, say, for example, a 9-year-old or an 8-year-old came with an exfoliated or an avulsed deciduous tooth. Now, a deciduous tooth, as a rule, is never reimplanted, right? So, the moment you see a deciduous tooth, nothing doing with coconut water, HBSS, Viaspan, milk, minocycline, a deciduous tooth is just thrown in your yellow bin to be sent for incineration, right? A deciduous tooth is never reimplanted, right? Because there's this chance of it damaging the succedaneous tooth. So deciduous tooth is thrown off, and you have to give a space maintainer depending on what the age of child is, depending on what the radiographic status is. If the permanent tooth is about to erupt, in the next 2-3 months, you don't have to give a space maintainer. If you feel that there's a long time that is going to elapse before the permanent tooth will ultimately come into the oral cavity, then you might as well give a space maintainer like a band and loop space maintainer or whatever, right? So this is how you're supposed to approach these tricky questions of avulsion. Okay, then there was a question: what is the type of fracture seen in an image? Now the image was, there was one clinical image, right, in which okay, there was a clinical image in which you had, I think this is repeated somewhere here also. Yeah, this was the image. This was the question. It's question number 4 is again repeated by mistake here. So this was a question in which one was a clinical image in which you have this, fracture line which was going in a, well, whether it was going in a mesiodistal direction or in a vertical direction. The idea was, the recall value is that there was a pulp exposure, right? So the fracture line showing a pulp exposure. But what made things, you can say, simpler for those of us who have memorized all the 9 variations of all the 9 types of Ellis and Davies classification was that there was another X-ray that was shown in the image. There was an X-ray. There were 2 images. One was an X-ray, one was a clinical image. And in that, it was clearly shown that this was a deciduous tooth. This was a deciduous tooth because in the bone there was a succedaneous tooth that was present, right? So any kind of fracture, whether it's involving the root or involving the crown or involving the pulp exposure, not involving the pulp exposure, chisel type of fracture involving part of the root, irrespective, all fractures of the tooth of the deciduous dentition are Ellis and Davies, are classified as Ellis and Davies class 9, right? They're class 9 fractures. So the answer straight away is Ellis class 9. Simple, right, friends? I'll just simultaneously see the YouTube link also, just in case you guys are um, posting questions here. Just a second. Yeah, yeah. All right. So I've opened my YouTube chat as well. All right. Okay. Great. Then we have identify the type of dental trauma shown. Now, this is a representative image, but basically the image was showing this only, that there was a luxated tooth. Number one, what is luxation? That is, the tooth has moved out, is displaced from its socket, right? In what direction? It was showing that it has displaced in a direction in which it has partially, fractured your labial or facial alveolar bone plate, right? This just like this. This is a classic diagram in your Anderson textbook. And what is the classification? Well, see, one you have what are the luxation injuries? The luxation injuries you have concussion, right? In which this is the least damaging. There is no displacement of the tooth. There is simply, tenderness and percussion, no mobility. Subluxation, mobility is present but no displacement. Then we have the various types of displacement. Now these two are the least serious ones. Then we have extrusive luxation, which is nothing but the tooth moved, displaced coronally out of the socket but not completely out, right? Then we have intrusive, as the word suggests, goes inside, it is impacted into the alveolar bone, and then in any other direction except for the long axis of the tooth, right? Except for the apicocoronal direction. What are the other directions in which the tooth can be displaced? Labially, lingually, mesially, distally, right? And that constitutes lateral luxation, right? So the answer is simple here. This is in a labiolingual direction. This luxation has taken place in a labiolingual or a labiopalatal direction, in which the root has got it has probably suffered a blow right from the front, and the tooth has suffered a lateral luxation injury. So that's the answer, friends. All right. What is the procedure performed here? Very simple. Basically, in the image, there was a gel, a pinkish, orangish, reddish colored gel, which was probably representing the electrolyte to complete the circuit for the testing of the tooth for the vitality testing, or rather, I would more correctly say pulp sensitivity testing by the electric pulp tester, right? You need to complete the circuit for an electric pulp tester. Classically, there was a digital display in which the figure was 20. So obviously that is the current value which was showing, right? When you start your electric pulp tester, it's a current value that is continuously displayed digitally on the screen, the small screen of your electric pulp tester device, right? So this was again a fairly simple question for people who've seen this in their clinics and preferably used it, right? Um, Metallic, another catch would be that the tip, it would definitely be a metallic electrode or a metallic tip. In a composite curing LED light, it's a fiber optic cable, right? It cannot be a metallic tip. So it's a classic electric pulp tester, no doubt about this. Now this is a image-based question again. See, practically everything is clinical and image-based question, except for obviously questions of dental materials. Dental materials also very conceptual, but unfortunately they have asked very hardcore theory based questions in dental material. But yeah, this kind of thing keeps changing, right? Okay, so this was a classic rubber dam isolation case, right? In which the recall value is that the bow was seen but not so clearly. Anyways, I'll tell you very simple. The parts of the clamp. Basically, the examiner is trying to gather whether the student knows the parts of a rubber dam clamp or not. So it's very simple. It's basically the clamp is the retainer or the retentive part which is going to hold the rubber dam sheet in place. That's number one, right? So it is going to be having these four jaws. One, these two jaws and 4-point contact. So this is say for example a labial jaw. This is a lingual jaw, right? This has to be connected. This has to be connected. So a bow has to be there. This is the bow. This is the transverse bow. It's in the form of a bow and arrow, transverse bow, which is present, which connects the labial and the lingual jaws. So it has to, a rubber dam clamp has to be with a bow. There's no doubt about it. So without bow, options get eliminated, right? The other thing is whether this rubber dam clamp has got wings or not. Now, wings are nothing but lateral extensions. This is a lateral extension to provide this platform. These are lateral extensions to provide more retraction of the soft tissues. Like on the lingual side, more retraction of the tongue. On the facial side, more retraction of the cheek mucosa, right? So that you get a nice, three-dimensional freedom of movement so that you can, do your root canal and your restorative procedures with ease. So the important thing here to see is whether these wings are present or not, right? So the wings are present, the answer becomes a winged clamp, obviously with the bow has to be there in the clamp. Or if it's simply that these wings are not present, so the clamp would be simply like this. It would just be having these jaws right here and here, simple, without these lateral extensions. So I've made this dotted line signifying that this is a wingless clamp, and obviously you will be having a bow. So this would be a wingless clamp, right? And obviously it has to have a bow that is going to connect the labial and the lingual jaws, right? So simple enough, right? You just have a basic idea of how it looks like. I know at the undergraduate level most of us are not using rubber dams, so this apparently simple question does become difficult if we've not seen these pictures. So this tells us that, please go back to your textbook, read your isolation chapter well, read at least the components of the rubber dam, right? You should know rubber dam punch, rubber dam frame, rubber dam sheet, the thickness of the rubber dam sheet. You should know the clamps, the two types of clamps, isn't it? In the classical rubber dam, wingless and winged. Bow has to be there, so no doubt about that. Best method for isolation for doing anything. Forget about vital pulp therapy. The best method for isolation is obviously rubber dam. So this is a simple question, no doubt about this. Okay, this we've discussed. Ellis and Davies, class 9, fractures on the deciduous dentition. Right, now this is a tough one here. Cross section is seen of a NITI file. Now, about 4 or 5 years back, I think 2018 or 19, right? This question actually came in which it was they had actually asked about the size of this file. So we're supposed to first of all identify what kind of nickel titanium file is this. As you can see here, friends, this is the cross section of the file which is asymmetric. You know, the cross section is represented by the circle, and the file is off center, number 1. Right, as you can see here, the file is off center. So out of the 4 corners of the file, only 2 corners are touching the root canal wall. So it's a asymmetric file, friends. And the identification of this file is that this system is pro taper next. All right, this is a pro taper next. This is a potential MCQ that can come. However, the examiner was smart enough this time. He did not stop here. Right? He asked the generation of this pro taper next file. So, in general, when we talk about NITI, nickel titanium files, there are 5 generations in general. First generation, in which the cutting efficiency of the file is not that great. They are passive cutting, and radial lands are present, right? That's a classic example, is a profile. Second generation, active cutting means positive rake angle, radial land absent. So positive rake angle, radial land absent. Classic example is pro taper. Pro taper universal bit, that is what I mean. Then we have third generation, in which special heat treatment is done to render the file more resistant to fracture, right? So special heat treatment of the file, and the classic example of third generation would be a high flex CM, high flex controlled memory. Then we have the fourth generation, in which the file is going to have a reciprocating movement. That means when the file is going to be connected to your endomotor, the advanced endomotor, in which there's going to be a dual function. While the file is going apically inside the canal, it is not just rotating in a clockwise direction. It's going in a watch winding motion, clockwise, anti-clockwise, clockwise, anti. That's fourth generation. And the fifth generation file is a file which is going to be having an asymmetric wave-like snake-like motion. So the because why based on what? Because its cross-sectional geometry is asymmetric. So it's going to be having a wave like or a snake like slithering motion, right? Asymmetric. And the classic example is your answer here, is your pro taper next, and your answer is fifth generation, right? All right, great. A patient complains of severe sensitivity. Now, this is severe sensitivity, all right, while eating ice cream. Now, this is a classic cold test, natural cold test. I'm not doing it in my clinic. Natural cold test, right? Which is a great test for pulpal vitality. So, number one, the pulp is vital, right? The sensitivity goes away as soon as as the cold stimulus is gone. So, the provisional clinical diagnosis is reversible pulpitis. Now, what is the treatment of reversible pulpitis? It's usually it's usually a simple restoration, right, friends? Now, however, there was an X-ray that was shown here, and well, in this X-ray, obviously there is PDL widening, but in the X-ray that was shown in the examination, PDL was absolutely normal. Periapical bone, that means there was no evidence of periapical pathology. So obviously, this is commensurate with our diagnosis of reversible pulpitis, in which there is no periapical inflammation. The tooth was not tender to percussion, nothing. Now the question is, if in such case, if in the X-ray, the caries is approaching the pulp, it is very close, or the caries or whatever, the radiolucency is approaching the pulp, very close to the pulp, then the answer becomes IPC. Why? Because indirect pulp cap is a treatment that you do for management of what is the inclusion criteria? Deep caries, right? And obviously, the prognosis of an indirect pulp cap would be obviously better when you are dealing with reversible pulpitis. However, based on recall value, forget this X-ray. Based on recall value, it was, you know, it was said by our friends, by our students, that the radiolucency was very superficial. It was more of an attrition defect, more of a age alteration, not caries. Like this, obviously, X-ray gives you a false kind of a impression of caries. This was more of a attrition defect, attrition abrasion kind of a defect, which was not approaching the pulp, right? So the first line of treatment here would be more, you can say more conservative, in which you would go for a desensitizing toothpaste, right? If the radiolucency was just involving the enamel and very superficial pulp, very superficial dentine. However, if the radiolucency is something like this in the examination, if in which the examiner is trying to ask us whether we have this idea of you know classifying this kind of a deep lesion as deep caries, and then he's basically trying to ask us what do we do in deep caries where the pulp is still not involved, then we do IPC. So based on the X-ray, your answer can be desensitizing toothpaste or indirect pulp cap. As far as yesterday's question was concerned, the feedback that we've got is that it was not really suggestive of caries. The radiolucency is very superficial, saucer kind of shape, and very superficial, involving mainly the enamel, very less dentine, and it was more of suggestive of attrition, right? So you start with desensitizing toothpaste. You won't start doing a cavity prep in a case in which there is attrition, right? All right. Okay, now again, a 12-year-old child comes to you with a history of long-term tetracycline use. There is mild yellow discoloration of your upper anterior teeth. Now, Okay, now this is tricky. Tetracycline stains. First of all, tetracycline stains, number one point. Historically, it was thought that they can never be managed. Right? Well, then came a phase in which they said that we can manage tetracycline stains by internal bleaching. That means internal bleaching or walking bleach. That means in a root canal treated tooth, internal bleaching is done when you put your sodium, perborate powder mix it with saline or distilled water and put it in the pulp chamber, right? In a root canal treated tooth. So the problem here is that you have to do intentional RCT. So this is not recommended if you can do other things. Then what is the other thing that is presently? So it can be managed by walking bleach, but not recommended. It is an aggressive treatment. To manage discoloration, you're doing an intentional RCT. Right? Now, the present recommendation is the present suggestion according to Cohen latest edition is that manage tetracycline staining by power bleaching or veneers. And then obviously you can do in aggressive cases, very, very, you can say deep rooted, very, you can say nasty stains, nasty tetracycline staining, which will not be masked by any kind of bleaching or even veneers. For aggressive cases, you go for full coverage crowns, you go for full crowns. So again, there is mild yellowish discoloration, so you do not go for full crowns here, right? Historically, it cannot be managed. Obviously, that is no longer the case. Walking bleach, internal walking bleach in a root canal treated tooth, I would not want to do here. The suggested present protocol is either do power bleaching. Now, what is power bleaching? Power bleaching is basically external bleaching only. That is, you can use hydrogen peroxide solution that is in the gel form on the teeth in a vital tooth outside, but you power it. You facilitate or accelerate the generation of oxide, superoxide, or peroxide free radicals, that is oxygen free radicals, by lasers or xenon plasma curing or lasers. Now this option is not given here. He is using heat or without heat, not an option here. Home bleach not be effective. HCl with air abrasive you can do, you may not do. But according to Cohen, if you have veneers as an option, which is the suggested treatment, then this option actually matches here. Now, some of you will say, why a 12-year-old child? Why do you want to give like veneers, like porcelain laminate veneers, and indirect restoration at such a young age? Friends, when we say veneers, Cohen simply mentions veneers, not necessarily indirect porcelain laminate veneers. You can do direct composite veneers as well. So the single best answer here would be simply veneers, right? And if you would have had, this can come as a multiple, multiple correct option question as well, like veneers, and another option they can give you simply power bleaching, and then obviously veneers and power bleaching will become the two correct options. They are the two best and you can say least invasive management of tetracycline stains according to the latest edition of Cohen. So I think that is clear here. Then you have, okay, another very important question. There was an IOPA X-ray, right, showing um, all the four lower anteriors, right? Now, in one of the anteriors here, there was a horizontal root fracture, which was right at the junction of coronal and middle third, but you would primarily classify it as a coronal third fracture. Yes, but it was not at the level of CJ. It was apical to the level of your crestal bone. This is the catch here. Earlier, coronal third fractures, coronal third horizontal root fractures, we used to consider them to have very poor prognosis. But presently, friends, if you have a coronal third root fracture, right, that which is below or apical to the level, below or apical to the level of alveolar crestal bone, then the prognosis is as good as a middle third root fracture and apical third root fracture. Now, by this, what do we mean? This means that what do we normally do for a middle, whatever we do for the immediate management of a middle third and an apical third root fracture, we are going to do the same for a coronal third root fracture in which the fracture line is apical to the alveolar crest. And what do? We simply reposition it, stabilize it, splint it with semi-rigid splint for 2 to 4 weeks. So the answer is simple: stabilize with splint. Now, if the fracture was right at the CEJ, which was not the case in yesterday's exam, then obviously the prognosis is bad. Then what do? You extract the coronal segment. Remove the coronal segment, you orthodontically extrude the apical segment and try to go for a post and core and rebuild the tooth. Right? That's a question for another day. Yesterday, the question was relatively simpler, right? Or rather, not very simple. I mean, this is the latest protocol presently, so you have to know this. This is written in your latest Cohen, and you have to manage it just like any other root fracture. All right. Now, this was interesting. There was a series of 4 clinical photos and 4 radiographs given, right? So basically, what it was showing was there were 2 central incisors, both the first clinical photo, both avulsed. The second photo and the X-ray, they were both put back, so they were both reimplanted, and a radio opaque root canal filling was seen. So most likely, what the endodontist did was the patient presented with avulsion, he put them back inside the sockets, did splinting, preferably for 1 to 2 weeks, semi-rigid splinting, and performed endodontic treatment. Right? Simple. There was a radio opaque root canal filling material. In the third photo, the splint was removed. Right? There was no splint. The teeth were there, obviously. The teeth had started showing discoloration. Right? And in the fourth photo, and more importantly, the X-ray, the clinical image and the X-ray, very peculiar thing was seen. The tooth had undergone resorption of half of its root, right? So if I show it here, the tooth had undergone resorption of half of its root, number one, and it was that area where the root was completely replaced by normal trabecular bone. That's simple. That simply brings us to the diagnosis of replacement resorption, isn't it? If the tooth if the tooth root is replaced by normal trabecular bone pattern, then the answer is simple, it's replacement resorption. But the peculiar thing here was now the root canal was practically clear. There was no longer any root canal filling material. So most likely the second X-ray either was of, say, a rate not of gatta parcha, because gatta parcha is not resolvable, right? So if it was gutta percha, it would have been, frozen or static here. It would have been here in the bone on the X-ray. It would have been shown on the X-ray, but it was not there on the X-ray, right? So most likely, in the second photo, in the second IOPA, if it was gutta percha, then during the next appointment, probably the dentist felt that the treatment was, kind of failing, or he should do something. So he probably retrieved the gutta percha. That's one, and replaced it with, say, calcium hydroxide, or that radio opaque root canal filling material was a radio opaque paste like Metapex. Irrespective, that does not make a difference, right? The fact is that the space occupied by the root is now replaced with normal healthy bone. So the answer is simply the option with the one having replacement resorption. So the examiner has done our job easier here. We just have to look at the right hint, right? So without any doubt, replacement is the option. Now this was a absolute rectification based question, based on physical properties of polymethyl methacrylate, directly taken from your Phillips. So according to Phillips, Knoop hardness number is 18 to 20, so this is the correct option. Tensile strength is about 62 megapascal, roughly around 50. So we can consider this correct or not. That depends on what other options we have. Compressive strength of PMMA, polymethyl methacrylate, is between 85 to 110. This again is near about 85 plus, say 76 megapascal. It can withstand heating of temperatures of up to. Now the chemically stable polymethyl methacrylate exists till 125 degrees Celsius. At 125 degrees Celsius, it starts to soften, and above 125 degrees Celsius, it starts to depolymerize. Right, friends? Now, in all likelihood, it can withstand heating temperatures of up to, this option was something like not related, not close to 125. If this was, say, for example, 60 degrees Celsius or 80 degrees Celsius or whatever, right, then obviously this option becomes the correct answer, right? Because this is absolutely false. So all are true except, however, this option was precisely 125 degrees Celsius, then I would go with compressive strength of around 76 megapascal, right? Because the correct value is between 85 to 110, right? So then I would go with compressive strength of 76 megapascal. The bottom line is that you have to memorize these four values. And one more thing, modulus of elasticity, 2.4 gigapascal. Please memorize these four values. Knoop hardness number, tensile strength, compressive strength, modulus of elasticity, and temperature, up to which it is chemically stable. So these are five values. 1, 2, 3, 4, 5. And you will be able to solve this question in this manner. Simple question, inability of a material to withstand plastic deformation is simple, brittleness. So stress strain curve is simply asking you the stress strain curve. This is material 1, right? This is the proportional limit. The straight line portion ends here, and this material is showing plastic deformation of what? How much? This much strain. So this is a pretty, you know, um, a ductile material. Whereas a material like this, stress strain curve is this, and this material, straight line portion here, and it fractures somewhere here only. So this material is showing very less or no plastic deformation. So this is a brittle material. This is a simple question asked this time, right? There can be various permutations and combinations of this question. They have been asked, wherein they ask you multiple correct answers, in which they give you these two graphs. They will give you differing slopes. They would ask you about modulus of elasticity. They would ask you about brittleness. They would ask you about toughness, and so on and so forth. Which of these is not a processing wax? Again, completely memory based. The mnemonic is bus. Bus, the bus that we travel in, bus and van. So all the processing waxes are, B stands for boxing, U for utility, S for sticky. So your casting wax is the answer of elimination, right? So the mnemonic here is bus. Boxing, utility, sticky. Simple, right, friends? So I think this solves our um, INI examination, cons, endo, and DM part. Right? We wish you all the very best at DBMCI, friends, and let's see. We need to work really hard, as you can see in the examination. Keep working hard, friends. There are conceptual questions, there are clinical questions, and there are hardcore theory-based questions. I cannot help you with that. Just keep on referring back to your Phillips in terms of these questions. The more you read, every time you'll forget. So keep revising these things day in, day out. This is what you're supposed to do at this point of time in your lives. You're going out, you're taking a bath, you're having your dinner. Just keep revising these things. No shortcuts here, right? Whatever shortcuts are there, we will be telling you. We are there to tell you. For example, this was a mnemonic, simple mnemonic bus, right? We keep, giving you memory aids and memory helpers too, and developing mnemonics in our classes. So, wish you all the very best. Keep working hard. For those of you who've really done very well, expect a good rank. For those of you who think you can do better, just stay at it. It is tough, but yes, it is doable. So we wish you all the very best. Thank you, guys. हेलो, हाँ, सुनीली बंद कर दो, हो गया। ठीक है। ओके।